Good morning, everyone. Slide discussion. History. A 55-year-old male patient with lung mass. These are the slides given to us. On low power view, we can see tumor cells infiltrating alveoli, and on high power view, we can see large polygonal cells with abundant amount of cytoplasm with vesicular nuclei and prominent nucleoli. Diagnosis: large cell carcinoma of lung. Introduction. Lung cancer is currently the most frequently diagnosed major cancer and the most common cause of cancer mortality worldwide. Globally, in 2018, there were an estimated 2.1 million new cases and 1.8 million lung cancer deaths. It is generally a disease of older adults with a peak incidence between 65 to 74 years. Only 2% of all cases occur before the age of 40. Etiopathogenesis. Most lung cancers are associated with a well-known carcinogen called as cigarette smoke. About 80% of lung cancers occur in active smokers or those who stopped recently. And there is a linear correlation between the frequency of lung cancer and the pack years of cigarette smoking. Industrial hazards increase the risk of lung cancer like asbestos, arsenic, chromium, uranium, nickel, vinyl chloride, mustard gas. Acquired mutations such as in adenocarcinoma, gain of function mutation in genes encoding several different types of receptor tyrosine kinase such as epithelial growth factor receptor, and in small cell carcinoma, loss of function mutation of genes like RB gene. Classification. Lung cancer is classified into small cell lung cancer and non-small cell lung cancer. Non-small cell lung cancer is further divided into squamous cell carcinoma, large cell carcinoma, adenocarcinoma. Adenocarcinoma of lung. It is an invasive malignant epithelial tumor with glandular differentiation or mucin production by tumor cells. Adenocarcinoma grow in various patterns, that is acinar, lipidic, papillary, micropapillary and solid. This is the image showing gross appearance of adenocarcinoma. We can see here peripherally located mass. Adenocarcinoma is the one cell type of primary lung tumor that occurs more often in non-smokers. The solitary appearance of this neoplasm suggests that tumor is primarily rather than metastatic. In another image, we can see different patterns of adenocarcinoma. Squamous cell carcinoma. It is more common in men and is strongly associated with smoking. Histologically, squamous cell carcinoma is characterized by the presence of keratinization and intercellular bridges. Keratinization may take the form of squamous pus or individual cell with markedly eosinophilic cytoplasm. This is the image showing intercellular bridges and keratin pus. Squamous cell carcinoma is mostly central in location. Small cell carcinoma. It is highly malignant tumor. They are the most aggressive form of lung tumors, metastatizing widely and virtually always proving to be fatal. It is comprised of relatively small cells with scant cytoplasm with ill-defined cell borders, finely glandular nucleochromatin, that is salt and pepper pattern, and absent or inconspicuous nucleoli. They are also called as oat cell carcinoma. They can cause Cushing syndrome, hypernatremia, Eaton-Lambert syndrome. This is the image showing microscopic appearance of small cell carcinoma, in which we can see small dark blue cells with minimal cytoplasm which are packed together in sheets. Large cell carcinoma. It is an undifferentiated malignant epithelial tumor that lacks the cytological features of other forms of lung cancer. The cells typically have large nuclei, prominent nucleoli, and a moderate amount of cytoplasm. Bronchial carcinoid tumor. They represent 5% of all pulmonary tumors. Malignant tumors composed of cells that contains core neurosecretory granule in their cytoplasm. They are classified into typical and atypical. They have excellent prognosis. On histology, we can see nests of uniform cells that have regular round cells with little pleomorphism. This is the image showing carcinoid tumor. On gross, they are seen as spherical and pale mass, and on microscopy the cells are small, rounded, uniform nuclei and moderate cytoplasm. Clinical features of lung cancer: cough, weight loss, chest pain, dyspnea, wheezing, hemoptysis. TNM staging of lung cancer. In T1, tumor size is less than or equal to 3 cm, surrounded by lung or visceral pleura, not invading main bronchus. It is further divided into T1A, T1B and T1C. In T2, the tumor size is between 3 to 5 cm or involvement of main bronchus without carina regardless of distance from carina or invasion visceral pleura or atelectasis or post-obstructive pneumonitis extending to hilum. In T3, the tumor size is between 5 to 7 cm. In T4, the tumor size is greater than 7 cm in greatest dimension or any tumor with invasion of mediastinum, diaphragm, heart, great vessels, recurrent laryngeal nerve, trachea, esophagus, spine, separate tumor in different lobe of ipsilateral lung. Various immunohistochemical markers are used in diagnosing the lung cancer. For example, in adenocarcinoma, thyroid transcription factor 1 and napsin A member of aspartic protease family are used, and in squamous cell carcinoma, P63 and P40 are used. Thank you.